I invite Dr. Arun Chandrasekharan, Senior Consultant Medical Oncology, Aster MIMS, Calicut. And Dr. Arun will be talking on the topic, the evolution of colorectal cancer care from chemo's reign to precision's whisper and immunotherapy. Over to you, Dr.
First of all, thank you to Dr. Madhu for the invite. So, actually this talk was supposed to be given by Dr. Arun from the GI team in DMH. So, I've got really big shoes to fill in. But, and the second thing, the topic was quite vast to cover both precision, that is targeted therapy and immunotherapy. So, we'll be, in the next 15 minutes, hopefully just focus on immunotherapy in colorectal cancer. So, this is something which, with time, is made great inroads in colorectal cancer. And the reason is, with the treatment of colorectal cancer is not what it was before. You've got multiple mutations, of which your RAS mutations are going to be the most common. And you also have so the major chunk of your patients are going to be RAS mutated, and then you have the wild types, but then you have multiple BRAF, MSI, pole fusions, and so on. And these mutations are quite important because you've got multiple targets which are available right now in our armamentarium, especially in metastatic cancer, where you can improve the outcomes of the patients. So, in practice, when you do an testing, a genomic testing for a patient with colorectal cancer, you need ideally to do a complete NGS, which includes all these genomic markers like RAS, MSI, BRAF, HER2, even pole mutations, because in the NCCN you have immunotherapy which is working quite wonderfully in the pole mutated patients as well. So in practice, maybe around 1 year back, we just used to do the RAS mutations and a BRAF with an MSI. But now we've got multiple targets, so a complete colon panel or a complete foundation one panel would give you, all the targets which can be used. In the localized setting, not in the metastatic, the base thing that you have to do is the MSI, which is critical. So this has been the era of chemo moving in, which started in 1950s with 5FU, and then you had irinotecan and oxaliplatin, and then came the era of the biologics, where you have VEGF inhibitors and EGFR targeting agents, and then finally came immunotherapy and precision oncology, which has taken over most of the second and third line treatments of colorectal cancer. So the era of chemotherapy still is pertinent. It still forms the first line therapy in your patients in a majority of cases. And the left versus right debate in colon cancer is still active. We know that MSI high is going to be quite common in right-sided tumors, but there are certain left-sided and rectal cancers that do have this. And for now, we use chemo plus Bev most probably in right-sided tumors, and in left, if you are RAS wild type, you have the doublet plus EGFR, or if it's RAS mutant, you use the doublet plus Bev. So with that, we'll jump into the main role of immunotherapy, that is in MSI high colorectal cancer. So, first of all, MSI high and MMR, these two terms we do use interchangeably, but actually on IHC, if you have a loss of MLH1, MSH2, MSH6 or PMS2, we call it as a deficient MMR. And a deficient MMR, if you confirm with the PCR, you call that as MSI high. So MSI can be high, can be low, or it can be stable. So in clinical practice, at least in my practice, we mostly do the IHCs. So what we look for is the deficient MMRs. And 15% of all colorectal cancers will have MSI high. And of those 15%, 2/3 are going to have sporadic mutations, and 1/3 is going to have the Lynch syndrome, which is familial. And in that 2/3, 50% are going to be BRAF mutated. So in familial Lynch syndrome, you're not going to have a BRAF mutation, whereas in the sporadic cases, approximately 50% of your patients are going to have that. So this is the latest NCCN guideline for advanced stage 4 colon cancer. And checkpoint inhibitor therapy has become the go-to therapy in this population of MSI high. And the main options we have is nivo plus ipilimumab, pembro or dostarlimab. So the data from this, the usage of immunotherapy comes from initially phase 2 trials of, you have the keynote and the checkmate, and they took patients who were pre-treated with chemotherapy and who were MSI high and gave them immunotherapy and found out there was 33% response, which is quite good. And even with nivo you had around 30%, but when you combine nivo plus ipi, you had almost 60% of responses. So these are great responses in patients who are pre-treated. So based on these, the FDA approved pembrolizumab and nivolumab and nivo plus ipi in this MSI high setting. So to confirm the findings of this phase 2, you had the keynote 177, which was the phase 3 trial, where they compared upfront or newly diagnosed patients of metastatic colon cancer randomized to pembro versus investigator choice chemotherapy. And as you can see from the curves here, you had wonderful responses. You've got a hazard ratio of 0.6 and a doubling of PFS from 8 to 16 months, and median OS improved to 30 months. It was not reached versus 36 months with a hazard ratio of 0.74. So this came at a cost of minimal side effects, let's say, because we know that the adverse events with pembro, they are mostly immune mediated, with the most common being diarrhea, fatigue and thyroid dysfunction, which we see quite commonly in our patients. So we had therapy which was safer than chemotherapy and more effective than chemotherapy. But there was a problem with the first, if you see the first 4 to 6 months. Here you can see that chemotherapy actually outperforms immunotherapy. Immunotherapy kind of lags behind on the curve, but after the end of 6 months it kind of takes over. Same thing with the OS as well. So this is mainly because around 30 to 40% of your patients are going to have primary resistance to immunotherapy. So those are the patients which you need to target, because these patients are MSI high, you expect them to do well, but 30 to 40% aren't going to do well. So the question was, how do you improve the outcomes of immunotherapy? So one of the trials was the checkmate 8HW, which gave an additional immunotherapy, that's a CTLA inhibitor along with a PD-1 inhibitor. So this compared nivo versus nivo plus ipi versus chemotherapy in the upfront setting in MSI high patients. And here you can see in the first 1 to 2 months, the curves are almost on top of each other, but then after that they start separating. So you were able to remove some of that resistance to immunotherapy by adding a second immunotherapy molecule. And here you have a huge hazard ratio 0.21, which is quite incredible that you see in oncology. And this is known as the Pelican's Peak curve because of the wide separation that you can see over here. So nivo plus ipi did extremely well, and it also took care of the resistance. But this comes at a cost of mildly worse adverse events, because we know in practice ipi is a drug which just causes side effects. So your performance status borderline patients are going to suffer more. But if you choose the right patient, you are going to get that benefit. And this was the updated results of the same trial in ASCO, which showed that this response is sustained, and the PFS2, which is the time to subsequent treatment, was also significantly delayed. So this tells you this kind of combination definitely does work in MSI high population. The second option to remove the immunotherapy resistance was, as we discussed before, 50% of your patients with sporadic MSI are going to be BRAF positive. This is the commit trial. This one looked at addition of immunotherapy. Along with that, they added chemotherapy plus bevacizumab. So here this was eti plus chemo plus bev versus just atezolizumab. And this trial is ongoing, and the results are not yet published. The second one is the SEMARC study, which targeted BRAF mutation, and they targeted BRAF with encorafenib and cetuximab. And this trial also, the results are still pending. So these are methods where you can get over the immunotherapy toxicity, the resistance to immunotherapy. The next, after stage 4 or advanced colorectal cancer, the next we have the usage of immunotherapy in localized colon cancer. So this was a new study, which was initially an exploratory study where they took patients who had localized colon cancer, and before doing surgery they gave immunotherapy. And this immunotherapy, they just gave 2 doses of nivolumab and 1 dose of ipilimumab. And as you can see, the majority of patients had pathological response, and almost 70% had complete pathological response. So this trial led to the continuation of it, and they added more patients. And when you give neoadjuvant immunotherapy in colon cancer, you can get close to 95% major pathological responses, which is less than 10% residual viable tumor, and 67% pathological complete responses. So these are very, very big numbers, and they've taken patients from stage 1, 2, and 3. So the NCCN currently recommends neoadjuvant immuno in the T4B subgroup of patients where you have difficulty. In this trial, they did not use much of adjuvant therapy, but in clinical practice, as of now, this is not does not enter the guideline. But if you have a difficult patient, and we have used it in one of our patients, my colleague, and we've had complete pathological response with 3 doses of immunotherapy. That's just 2 doses of nivo and 1 dose of EP. So this is something definitely to look forward to. So from colon cancer, this is rectal cancer, and this was the famous dostarlimab trial which got splashed in the news, where 12 patients were given immunotherapy, which was dostarlimab, and they had complete clinical response. And they were actually initially planned for surgery and radiation, but they didn't go ahead with that. They kind of observed these patients, and as of now, they're still under follow-up, and I don't think there's been a recurrence as of now. So normally an MSI high patient has quite low chances of pathological response with chemo. It's around 7 to 8%. But with immunotherapy, the clinical response is almost 100%. Path response is complete path response is almost 60 to 70%. So there are further trials, because the dostarlimab trial was a very small trial. This trial initially looked at giving neoadjuvant immunotherapy, that was EP and nivo, in rectal cancer, and then doing radiation, and then finally surgery. But after the seminal results of all the immunotherapy trials, they stopped. They had a protocol amendment, and instead of that, they gave immunotherapy to rectal cancer patients, and if they had excellent clinical response, they observed them without surgery or radiation. So this trial is also ongoing, and the results should, let's say, be a little scary for our radiation and our surgical oncologists as well. But again, this is a very small subset of MSI high patients. The other group of patients who benefit from immunotherapy is the POL and POL-D mutations, because POL mutations, they are a DNA repair mechanism which does proofreading. So when you have a POL mutation, that's going to lead to excessive DNA damage and exposure of neoantigens, and that causes immunotherapy to work much better. So these patients are also patients where you can use immunotherapy. I think this is the final slide. With immunotherapy, there's always the question is, if you stop immunotherapy, that's the question which was asked. You're not doing surgery in some patients, and you are following them up. You need to give immunotherapy indefinitely. So this was a series from MD Anderson, and they gave around 64 patients immunotherapy, and they gave it for around 1.5 years on average, and then stopped therapy and followed them up for 2 years. And in 2 years, out of all the patients, 88% did not have a recurrence. Around 12% had a recurrence. That's 8 patients. And once they restarted immunotherapy, 7 of those 8 patients responded to immunotherapy. There was only 1 patient who did not benefit and had to change therapy. So this is retrospective data, but this tells you that you can stop immunotherapy, especially when you have pembrolizumab, which is usually supported for 2 years. You can probably stop immunotherapy and keep these patients under close follow-up. Yeah. So last slide, and yeah, this is the last one. This is a summary. So if you have metastatic MSI high colorectal cancer, right now the standard of care is giving immunotherapy. You have pembro and you have nivo plus EP, and I think nivo plus EP is just slightly better. In localized MSI high colon cancer, you have the option of neoadjuvant nivo plus ipilimumab, but again this is in mostly in T4B patients officially, we need more data, the phase 3 data to see whether you can skip adjuvant or not. In localized rectal cancer, there is an option of NACT with dostarlimab, nivo or pembro, and patients who have very good response, who are not willing for radiation or surgery, you can keep them under follow-up. Again, this is person-to-person basis, but immunotherapy does work well in these patients. And finally, whole mutated immunotherapy, metastatic cases, definitely there's a role of immunotherapy. Thank you.
Thank you, Arun, for a detailed discussion of
Immunotherapy in colorectal cancer. So now open for a discussion for question and session.
So if MSI is low, you do oncotype takes or you do tests like RAS mutation and panel, or you do
So first, in our practice, first we do the IHC. When you have a biopsy, we kind of know.
after that
Yeah.
you do
NGS.
NGS full
Yeah.
or you do in piecemeal like
Yes. So that depends on the patient's affordability also. So the basic one, we've got free testing in RT-PCR for this one, for your RAS mutations and BRAF. So that is covered. So that's the bare basic that we do. But if a patient is affordable for everything, then we have the Colon panel, which looks at all these mutations, and the extremely affordable foundation one, or the 200 or 172 gene panel. That's what we do. So it depends patient to patient. Somebody is not too affordable for immunotherapy in a way. The whole making them spend 80 to 90,000 for the complete panel might be not very cost effective. So we do it as per the patient's, we kind of do his choice.
So MSI is low.
Yeah.
How you proceed? So like you give anti-angiogenic drugs first, or
So again, if it's MSI stable, like you don't have MSI high, so immunotherapy is out of the equation there. So then we looked at whether it's left-sided, right-sided, and the KRAS mutations. So if it is a right-sided tumor, as I said, normally we give a doublet, which is FOLFIRI or FOLFOX with bevacizumab. Left-sided tumors, we look at whether the RAS mutation is there. RAS mutation means EGFR is not going to work. So then we use again doublet plus bev. If the RAS mutation is not there, it's wild type, I think EGFR is what we prefer, the left-sided colorectal tumor, means left-sided tumors.
MSS status, stable.
Yes.
Stable. Colorectal,
Yes.
relapsed.
Relapsed.
Relapsed after 4-5 years. MSS status, but TMB is high.
Yes.
So, what is your take on immuno in that situation?
So TMB high, first line I would probably not use. I would stick to MSI high as the first line therapy. Second and beyond, yes, probably. I think I would still start with the doublet, and then after that, give them chemo, yeah. And after that follow. Because TMB again is not a definitive marker, it's not in the permits. There is some recommendations after the first line. So TMB is recommended in that setting. But first line, MSI would be the only indication I would say.
And MSI, you are happy with that INC based,
Yes.
or suppose if it is in that MSS, you want to go with the PCR also?
In practice, if I have
You don't do it?
no, we don't. I'm pretty happy with the this thing, protein expert. I think there's some concordant studies which have shown, you don't need to, once you have the IHC, which is showing nothing, MSI stable, intact expression, then you call it proficient MMR. We do not do a test. Later on, in the subsequent, probably when down the line, suddenly we think of NGS. That's where we had some, I think very rarely we had one surprise which came out positive, but I think the patient did not respond to it. I don't know whether it was a test problem or not. IHC is pretty good.
Thank you.
So one small note. So like most of the radiation oncologists will be seeing for rectal cancers 1 or 2 at presentation liver mets.
Yes.
In those cases, how do you proceed, sir?
So that's again, that's a multidisciplinary decision. Now, is it resectable liver mets which are there?
That's what exactly.
So there are 3, I think even if you see the NCCN, there are 3 options you can do in this setting. Normally in our practice, if you have liver mets, we kind of We kind of look at the Fong score also, which tells you high CEA, which is there, and large liver mets. Normally, if it's quite, you're talking about rectal cancer, right?
Yeah.
Oh, rectal cancer, then normally we start out with probably short course, this thing RT followed by neoadjuvant chemotherapy, a TNT kind of approach. Probably after 2 months, we do a repeat scan, see if everything is responding. And at the time of surgery, we can keep the surgery towards the end or take it midline. That's again questionable. Depends on what your tumor board decides. But normally we give chemo at the end of that. We then kind of do the surgery. Also, the second option is just starting off with neoadjuvant, seeing if the patient is completely asymptomatic, no rectal issues and everything. We even have started with neoadjuvant, and then after that look at the response at 2 months, and then seeing good response and given RT and then proceed with surgery as well. So all three, I think are valid.
Patient with pulmonary embolism
Yes.
with this rectal cancer building